Thanks, everyone. I appreciate you taking time to come and listen to our presentation, and thanks for the invitation to present here. Again, all my colleagues have done an amazing job of demonstrating that fMRI is really a very useful tool in clinical populations, both adult and children. However, there are some cases where, despite our best efforts, fMRI is not feasible, or other modalities are not feasible. So let me see if I can actually advance. Yeah. And I point to. Thank you. Okay, there we go. I do not have any disclosures. So when we talk about what could be an alternative if these other modalities are not feasible, we really want to think about something which is similar to the gold standard. So the gold standard still is direct cortical stimulation mapping. So what is something that is much closer to that but can be done non-invasively? So that would be where we bring in TMS, transcranial magnetic stimulation, as a way to look at brain function and really understand either language or motor networks in these patient populations where perhaps other modalities are not useful. So what's TMS? I know most of these people in this group here in this audience probably already know, but it is a way to non-invasively stimulate brain areas, and I believe, is this the marker? Yes, excellent. So basically it's a charger, a capacitor which holds a lot of charge, and when we discharge it, there is a dampened sine wave that is actually passing through this coil here. So right-hand rule, there is a orthogonal magnetic field. That's what is actually stimulating, that goes through the scalp and the skull without any attenuation, and we can actually stimulate certain brain areas that are directly underneath this coil. So this is the coil that we usually use, which is the figure 8. And one of the limitations, of course, is that it can only stimulate cortex, which is superficial, but fortunately most of the language and motor areas are in this range. So we're happy to, we won't usually have any issues with that. So what is the role of TMS in pre-surgical mapping? It is definitely used to localize function, for example, motor and language areas. And also, similar to the fMRI, we can actually demonstrate the laterality as well. So in this case, it is then equivalent to the other gold standard, the water or the sodium amytal injection to map the lateralization. It is FDA approved in the US, so it is used for motor mapping and language mapping. So it is a clinically valid application for, and there's no age limit. It can be used across all populations. So this is kind of what we do. It's an image-guided setup. So technically, it's not really an imaging modality. What we do, we apply TMS and we elicit a behavior. But we use the imaging as a way to navigate, to know where we are targeting the TMS, as also to represent the actual findings. So rest of the talk, you will see that I'm showing images on the MRI, which show where we found these behaviors that were elicited by TMS. So that's kind of what it looks like here. So for language mapping, we have a much more limited repertoire. We use either an object naming task, or in some of our younger children or cognitively delayed adults as well, we do use much more simpler color naming task. Oops, sorry, I didn't. It just basically here, they just have to name the color. So it's on, and so these are event locked. So when the picture comes on, the TMS is locked to the presentation. So these are all very easy to do, and it's event related. So it's very similar, again, to cortical stimulation mapping, where you, while the person is performing the task, you are applying the TMS stimulation. So just to give you an idea what kind of brain areas are covered, so this is just pretty much all the temporal regions, temporoparietal regions, and of course the inferior frontal gyrus. And you know from previous talks that these are classic language areas. So just to see, I wanted to demonstrate to you before I go, what are some of these errors that we do elicit during TMS?
Microphone. Hand.
Okay, so this is 11-year-old. So at baseline, she was perfectly fine. She was able to name the object, but during TMS stimulation, you can see she was pretty frustrated and unable to name the object.
Corn.
All right, she's a classic. So at baseline, it's a carrot, but during TMS stimulation, she labeled this as corn. And of course, that's a semantic error, which is a very typical TMS-induced error.
Guitar. Guitar.
So this is a little more subtle error caused from TMS. It's just a little bit of hesitation, slowing in response time. So these are what we call as performance or production errors.
Clock. Clock.
All right, this is just a typical, I just wanted to show to you that these are we have some really cute kids. He probably is one of the cutest. But to show that most of the TMS stimulations do not result in any error. So and it's well tolerated by this population. So I just wanted to highlight that. So, but there are, as I said, there are many times, often, the other modalities do fail. So that depends, because these modalities are still, they're correlational, they're hemodynamic responses, and they are depending on patient cooperation and performance. Again, I think Lee demonstrated really clearly that patient age is really important. And there are some other important things that are going on that are directly affect the fMRI, is the neurovascular uncoupling. Because when we are really talking about the neurovascular coupling, that is really the fundamental basis for the fMRI signal. So we do want to highlight these issues. And then sometimes patient is just not able to perform a task. So I want to show you an example of that. And many times, maybe the other modalities are not available. We have had occasionally where our fMRI system is broken down, so we do want to have other options available as well. So I just want to show you this one kid. He is a 17-year-old, undergoing phase 1 evaluation for refractory epilepsy. He had a left hemisphere cortical malformation, but he had a lot of comorbidities of anxiety, ADHD, autism spectrum disease. So he was really not able to lie still in the scanner. So he had to be sedated for MRI, and I think as Chris already showed, there's for epilepsy mapping, the anatomical MRIs are really the most important one. So he had to be sedated so that we have a good quality anatomical MRI. So he did not undergo functional mapping. However, he was able to successfully complete TMS motor mapping. As you can see, both his left and right motor cortices for the hand and the leg were mapped, and he did undergo language mapping. So he had some areas where there were semantic errors and performance errors, in fact, on both hemispheres. So we did not really see any language errors in the inferior frontal gyrus, but temporal areas were able to be mapped successfully. So this is a good example where TMS would really be helpful for this patient. So as I said, the patients who cannot stay still, or sometimes our patients have complex epilepsy syndromes. They have epilepsia partialis continua, where they are constantly moving their hands, or face twitching, or so they are not able to comply with the demands of the fMRI. Maybe they are claustrophobic. Also, they're not able to perform tasks, and as Lee mentioned, so it's really, really important. Patients sometimes do fall asleep in the scanner, or they may not be able to follow the instructions. So in these cases, we really have to come up with an alternative for these patients. So here is another really interesting case. This is a 3-year-old patient, and so when we do really young children for TMS motor mapping, they just actually sit on the parent's lap, and we are able to still register their head to their MRI, and we're able to apply. So it's a very suitable to do young children this way. And you can see that this child actually underwent passive motor mapping. So somebody in the scanner was moving their hands while acquiring fMRI, and actually it was successful, but mostly you can see that the activations are in the post-central gyrus. So it's not really in the primary motor cortex. And for this kid who has a tumor here, very close to the in the precentral gyrus. So it's really important to map his motor cortex. So we were able to successfully map his motor areas with TMS, and post-operatively, he had no deficits because they were able to, the surgeon was careful not to interfere with the motor areas mapped by TMS. Similarly, there's another 2.5-year-old female with tuberous sclerosis. So you can imagine they have lots of tumors in the brain. Again, fMRI was attempted, but it was much more post-central activation. But we were able to demonstrate with TMS that the motor cortex was normally localized actually close to this tuber. Fortunately for her, the tuber that was actually causing seizure was much more anterior. This TMS was actually validated by the direct cortical stimulation as well. So we know that these are real accurate motor maps. And so again, the patient had good outcome. So again, when the children are young or they're unable to follow tasks, so fMRI language mapping is definitely a challenge. So we, in our series, we had 138 patients who underwent both TMS and fMRI. And you can see that 91 were attempted awake, and they were, most of them about 20% failure rate, again, similar to TMS. But when they were sedated, about 75% of them failed. So here is an example of that. When we are doing fMRI activation, there's really no meaningful, statistically significant activations in the language areas. But to show that that same child underwent TMS, and we were able to successfully map language regions in the left. This was actually a left hemisphere dominant for this child. So again, to demonstrate that when these other modalities fail, TMS is a good alternative. Just to highlight that most of those ones which had failed TMS, failed fMRI, TMS was successful. Again, I mentioned earlier about neurovascular uncoupling, which is really, really important. So this is a really interesting study. It's a case report in this 4-year-old who had arteriovenous malformation in the precentral central areas. Again, fMRI mislocalized the activation, whereas in this particular child, both TMS and MAG results indicated correctly where the motor cortex was, and that was indeed confirmed intraoperatively as well. Again, demonstrating that when patients have these unusual abnormalities, it's really important to know what the limitations are of other modalities. Again, brain tumor, another really important condition. So we are working closely with St. Jude Children's Hospital, which is a premier pediatric cancer center in the US, and they have a lot of brain tumor cases who do come for mapping at our center. So about 20% of our patient populations are brain tumor children. So you can imagine for them, it's really important to make sure that we are able to successfully map the motor region. So here are some examples from these papers which show there is a altered cerebrovascular reactivity, and therefore, it's really important where fMRI failed to localize function. So it's really important to consider alternatives. So I wanted to just highlight a couple of cases here. So here is one who had a left temporal tumor here, another one here. Both underwent successful TMS mapping, and that was useful in operative decisions. So I wanted to highlight to you when patients are just not able to perform the task. So I want to just start with this video. So you can hear the TMS clicks, and you can also see the leg move here. And then this is the other side. So again, you can hear the click, and you can see the leg move. All right. So, but you can see this person is on the wheelchair. So what's going on? So this is the motor mapping. So it's perfectly normal localization of the motor hand and the leg area. So what's going on with this child? So this is a 14-year-old with a history of sudden onset. She just got up in the bed one day. She had weakness, progressed rapidly, and she's not able to move around. She's in a wheelchair. And so she was worked up extensively for any of the neurological diseases, including the Guillain-Barré, but everything was negative. So finally, she was diagnosed to have a functional neurological disorder. So in this case, how are you going to find out what's, if her leg motor is normal or not? Because she's not able to perform the task in the fMRI. But TMS is a nice way, is a nice way to demonstrate, to confirm that the motor network is normal. In fact, it's been shown that this kind of demonstration to the patients that they're able to move their legs is actually therapeutic. So TMS is actually used as a treatment for these individuals as well. So that kind of leads me to my next short segment about treatment. So TMS is also unusual from other modalities, which are diagnostic only. We can actually bring in the therapeutic components as well. So because TMS can change the excitability of the cortex that we are stimulating, it is able to be useful as a treatment modality. And it's been tested in these different epilepsy syndromes. And the important part is that the effects are long-lasting. So there are some evidence, and there are 6 studies which did not show any difference, but 2 studies did show a significant effect of TMS. So the effect sizes are not very promising. However, I think more work needs to be done. Again, in status epilepticus as well. So in conclusion, I want to just highlight that TMS is an important tool aiding in mapping motor and language cortices. It has some promise as a treatment, but it is safe to use in children and adults with neurological disorders. So I'm going to stop there, and I'm happy to take answers as well. Thanks for your attention.